today to discuss and train you on conducting emergency health risk assessments. So today we have, my name is Kathy Beauregard. I'm with the emergency, or health, what do I call it again? Health Emergency Preparedness and Response Team. And with me, Jill Pertimosh. And assisting with AV is Susan Lorden, our program assistant. And helping at the front desk is Renee Larocque. So without further ado, we'll get started with our session. So today we're together from 8:30 until 10. And then at 10 we'll take a 20-minute break or so. And then session number 2 will begin at around 10:20. And we have a guest coming from Health Canada, and Martha Robinson will be joining her as well. So I think some of you are staying for that second session. When you first signed in, because it was a bit of a rush, I didn't ask you to sign in for the second session. So if you are staying for the second session, perhaps go back to that sign-in sheet and indicate that you were here, and that helps us track who's attended what session. So if everyone's familiar with the venue, as you know, washrooms are just down the hall, and I think that's probably all you need to know about this facility. So enjoy the morning, and hopefully if you have any questions, just stop, just put your hand up, and we'll try to answer questions as we go along. All right, first slide, please. So today, the objective of the session is that public health nurses will be competent to conduct emergency health risk assessments. And you'll understand your role within the incident management system, how a health risk assessment is conducted in an emergency reception and lodging center, and home visits. We'll be looking at documentation standards for completing the emergency health risk triage tool, and understand your requirement for personal and professional emergency preparedness. Next slide, please. Now, the function within the OPH emergency plan, hopefully all of you are familiar with the emergency plan. If you haven't had a chance to review it, or it's been a while, it's a good idea to review it annually to make sure that you know any changes that have happened. This is the function that we are focusing on today. The hygiene and public health function, the assessment of vulnerable population tasks. So within the plan, OPH is responsible for this function. So that's within the city emergency management plan. So then we, within our OPH plan, figure out who is going to do and fulfill that function within the city plan, and then of course within the OPH plan. So within OPH, HPDP is the lead branch that provides the nursing capacity to do this function. And clinical programs are the backup or partner function. So usually in these emergencies, HPDP is the first branch to mobilize their staff. If it's kind of all hands on deck, then we would probably look to our clinical programs. But typically within the continuity of operations plan, we really try to protect our hands-on services, frontline clinical services. But if needed, we would ask our clinical program staff to step in. So the action is to conduct health risk assessments with populations who may be at elevated risk as a result of the emergency, coordinate necessary follow-up actions on identified needs, and some of the plans that will help you are the health risk triage guide and tool that we're going to be going through today. And we also have a health emergency plan for priority populations. And that address the needs of the vulnerable populations. One more point is that paramedics are a support in this function. So if they may be at the location assisting with the health risk assessments, and I'll show you sort of their part in the plan as well. So where might emergency health risk assessments be conducted? In an emergency reception and lodging center, for example, in response to an evacuation for a large fire. That's the most common reason for these ERLCs. Our city partners activate the reception center, they call us, we join them as part of a team, and while the fire is put under control and they find places where people can go when they've been displaced from their homes. It's the most common reason that we see these centers being established. You might need to do them during emergency response home visits, for example, a drinking water advisory, ice storm, flood, and we have had examples of all of these situations in the past. The newest addition for this function is we've added this function to the draft OPH anthrax response module as part of this chemical, biological, radiological, nuclear, or explosive plan. So if there was an incident and people were being kept at a site where they need to wait for results of testing, was it truly an anthrax exposure, they might ask people to stay there. So nurses could help assess if they have any health issues in remaining at that site. The purpose of the emergency health risk assessment is to determine whether staying at that reception's ERLC or in their home will endanger their physical or psychological health of the individual or of the family. Because of the emergency as something, are they in a situation where they don't have what they need to support their health needs? Are they at a shelter without their medication? Are they in their homes and the emergency has caused damage to their homes such that it's not safe for them to stay there? So the nurse is in a position to assess their physical needs and what they might need to stay where they are, or whether they need to be moved somewhere else that's more appropriate to meet their health needs. Next, please. Now, as nurses, you're used to doing an assessment of people's health. And usually, we'll do a comprehensive assessment, make sure that we're addressing physical, emotional, spiritual, everything that we do as a comprehensive assessment. It's different in an emergency. It's a focused assessment based on the emergency situation. You need to triage to make sure that there's nothing urgent they need to address, and then you'll categorize people to decide if something is really urgent, high risk, low risk, and so that you know who you need to focus on. Because if there's a large number of people, you don't have time to do the full assessment, you need to focus on what's most important. So you used your nursing judgment to determine which categories or which aspects of their health you need to focus on. And once you've determined the issues, you can follow through with education, psychosocial support, referral, and any follow-up that you need to do to make sure that they can stay in that situation, or if they need to be referred elsewhere. Next slide. All right, so that's the context of what we're doing today. Does anybody have any questions before we move on to, now we're going to activate an emergency situation, how it all rolls out, and how it will all work. Any questions before we move on to the next section? Yes?
really looking at is the worst case scenario. What happens is a lot of our responses are just one-offs. There's one building on fire. I'm thinking there's been instances where under normal conditions, when you're talking about a real disaster, paramedics will not be at the shelter. Paramedics would not, they will be in the field doing what only they can do, which is first aid, patient stabilization, transport to hospital. But when you've got one incident which doesn't require a lot of resources, it ends up that the paramedics end up going to the shelter as well. And this happens many times with these small emergencies. And so they're there, and they want to do what they do. So really, this tool was meant, you're the primary person doing the health assessments in a shelter. And it's, when they're both there, you just have to work out. They know about our tool, and they know what we do and what they do. So when they're there, we've divided it up so that the actual physical assessment gets done by them, and the rest of it, the functional, emotional, situational assessment gets done by us. You know, what meds are they on, what's their history, communication, and you'll get into that. But that's the way it's supposed to be. That's the way it was supposed to be done. But it just ends up that sometimes we have a lot of people for a small response. So I'll move right into now the activation of an emergency reception and lodging center or a home visit. So when there is an emergency situation, there's two ways, and there's two different scopes. So there's large disasters where everybody's on, where the city gets activated, and we get notified from the city that there's been an earthquake or there's been some other major disaster, and they're activating the city along with us. And so we get activated through the corporate duty officer system. We assign an incident management system team for OPH, and that team assigns a task force team to the one site. It might be two sites, it might be more than that. And that operations chief, and it works on down until the task force leader gets assigned and gets deployed. Staff get notified through Cinder Voice. We haven't done some exercises in Cinder Voice for a while. Stay tuned. We will be doing some exercises shortly to remind you all about how that's how you get notified after hours, as long as your information is current. The cell phone that you've got listed is the one that you're using right now. Excuse me. And the other way that you would get activated is if we own the situation. It's a health emergency, such as the drinking water, food poisoning, whatever, and we're the ones that would go into enhanced response. Next. So what are the responsibilities of the task force leader? Within 60 minutes of the activation, so 60 minutes from when OPH was deployed, was notified that they needed to deploy, our task force leader arrives at the site. And you report into the site incident commander. That could be OPH, or it could be somebody from the city, whoever is the commander on the site. And you work with the site incident manager, incident commander, and the IMS team to plan what the role for OPH is going to be. You know, it differs from emergency to emergency. Whether it is, you know, staff that have just been evacuated because it's not safe for them to be in a certain situation, or they might have been through a harrowing experience and they've been rapidly evacuated. You negotiate an appropriate space. So you don't just go in and decide where you want to go. You want to be somewhere where you can be easily reached by the staff in the center that want to refer a client to you, or where the clients themselves can easily reach you, and that you can be aware of what's going on in the shelter. You sign in your staff as they arrive, and then you brief them as to what are the objectives of the OPH deployment. Next. So you supervise your staff as they arrive, and you keep the OPH operations chief. Now, in a small incident, the OPH incident manager and the operations chief would very likely be the same person. We wouldn't have IMS shrinks or expands according to the size of the operation. But you would know when you get deployed, and you make sure that you know who it is that you're reporting in OPH to keep them informed of what's going on, how your staff are doing, and what you might need as resources from OPH. You conduct a hot debrief and you document everything. Documentation is very important. I'm going to go over the sheets in a few minutes. You document what the activities that go on, anything that's going to help afterwards when we do a debrief and a report, an after action report. And then after the event is closed, as the task force leader, you will also participate within, usually within a week, a cold debrief. And you collect all the documentation, and when we go over the bins, we'll show you how that is kept securely. Next. So, for the PHN, while you're in a shelter, you wear your blue OPH vest so that you'll be easily identified by the other members of the IMS team within the shelter, and your OPH identification. You arrive as well within 60 minutes of the activation, and you report to your task force leader, and this is very important. Under IMS, you only report to one person, and so you're that way there's no inconsistencies in what people are hearing. If you are the first person to arrive, and you actually get there because you live closer before your task force leader gets there, you're in charge for OPH until you get relieved by somebody to whom you report. And then you would transfer the role of responsibility. And you participate in the briefing that occurs when you arrive. So, what are your responsibilities there? Clients will be referred by other team members within the, could be very often it's Red Cross, who are doing the registration of clients. And as they're doing the registration of clients, they mention that they haven't got they're not feeling so well, or they're really upset, or they left their dog behind or something, and they've got some issue with their emotional or physical health, and they'll refer them to the public health nurse. It might be the social worker who's actually meeting and greeting people as they arrive at the shelter, who notices that there's something off with this person. You conduct the health risk assessment and you document it on the tool. Then we will follow up with identified actions as you're required. So when you do that assessment of what is the complaint, and then you decide, if you decide that it needs referral, you do that referral to the proper persons, and Kath is going to go through the form. You monitor clients. So in a northern evacuation, for example, you might be in that shelter for a long time. We might be there 20 hours a day, 18 hours a day, and so while you're there, you're kind of monitoring how things are going. Some people have delayed reactions to what has happened to them, or the shelter might be 4 hours. So everyone is different. Any significant issues that you come across either with your clients or the situation within the shelter, you report to your task force leader. And again, very important, you participate in this hot debrief, and then you, at the end of the shift, we found that in H1N1, people were going home with baggage. They'd had a rough shift, people have been complaining, they'd been arguing, they were unhappy, you were working hours that weren't your normal hours. and your family was at home and it was causing you hardship and you were getting burnout. We found that for those teams that did a hot debrief before they left, you just got together with your team and you had a little, maybe a bitch session. You just got it off your chest, and it made people feel much better in the long run. And afterwards, when you make sure that any experiences that you think need to be shared, get shared in the cold debrief afterwards. So this is the reporting structure, and this is important because it's a learning curve for people who don't get to do this very often. So we've got, this is how it works. In a lot of situations, the Emergency Operations Center is actually virtual. The reporting is done by phone. In a major operation, it would be, there would be people sitting there. In a really major operation, they'd be sitting there all the time. So you've got from the OPH on the right, you've got the OPH side, and that is your incident manager and or operations chief, who reports up to the OPH duty officer, who then reports up to the Emergency Operations Center. In this case, the health task force leader gives information on what is going on with public health to OPH, to the SCC, whether it's virtual or not, and asks for any support that they need on the site. The health task force leader reports up to the site incident commander. So there's a difference between giving information and reporting. Reporting is the person you're accountable to, and that person also reports up on the whole site to the Emergency Operations Center. Next, please. So if this is in a shelter, and you've got exactly the same thing, but here it's just a little expanded. You see the health task force leader. It might be day one where you've got inspectors on site doing, checking out sanitation, the food service, the health risk posed by the actual shelter, and you've also got the nurses that are doing health risk assessments, and they report up to the one person. You've got other people in that team. You've got people, social workers providing psychosocial support and personal services support. You've got the Red Cross doing reception and registration and first aid. And you've got Parks, Rec, and Culture who are actually operating the shelter. And all of these different teams report up through their own mechanism into the site incident commander. So the responsibilities of the health task force leader: you sign in the staff, and you brief the staff so this is when you're in a home, or rather than a shelter, you have to do home visiting, such as we did in the ice storm. You brief the staff on the safety measures that they will keep them safe. And these are all on your reference sheet. You've got a home deployment kit, and all of these safety tips and everything you need to know about a home deployment are on your reference sheet. So the task force leader provides the route assignment maps, and we've created, and we're going to go over the bins. We've got all of the tools that you need to know in there. We've got maps, we've got handouts to give you, we've got, and the task force leader will supervise the staff as they conduct home visits, assist with any required follow-up, and you will be using cell phones to keep in touch. People will go out in pairs, you'll keep in sight of each other, you'll report back any issues to the task force leader. And so this is a little different, the need for safety, the fact that you're out into the field, the weather might be bad, it might be dark, these are all, and it might be unknown territory, and it's often rural territory. This is the difference between what you're doing in the field in a home assessment and in a shelter. In this instance, you wear your orange vest. This is for visibility. It also helps when you're going to knock on somebody's door at 6 o'clock in the morning, that you've got that orange fluorescent vest with health on it, that people will recognize that you're not Jack the Ripper, but you're actually there giving them some important information. You'll have a route assignment, you'll have maps, and again, safety guidelines to make sure that you don't come to any harm. Some of these places are unknown territory. It's very different than being stuck in a city-owned community center. You might be asked just to provide, like in a drinking water advisory, to provide information and to answer questions and a bit of education to the people. Or it might be day 10 of a power outage and an ice storm like they had in Toronto last year, where it went on for 2 weeks in some neighborhoods. You're actually assessing the physical environment that the people live in, whether they've got water, whether they've got heat, whether they've got their medications, how well they're doing, how all the family is doing. So it's a little bit more, it's not just the individual, but they're actually their surroundings. And again, you have to report any significant, you often get people that are staying in their home, especially the elderly, long after they should have left, and they just can't leave their personal possessions. It seems the less you have, the more precious they are to you. You document on your OPH responder activity log and the health risk assessment tool. So now I'll turn you over to Kathy to talk about that famous tool.
So before I jump into the tool, I just want to open the floor to any questions that you got about working in the Emergency Reception and Lodging Center, aka shelter. So we're using the terminology back and forth. Might be a little bit confusing, but the official name is ERLC. So just to clarify that. And any questions about the activation, the INS structure, your role within that structure before I go forward, just to make sure that you clearly understand what Jill presented? Yes?
So with respect to the center voice, how much information is transmitted through center voice so folks would know when they arrive on site who the TFL is, for example, and if there's resources required like signage, that sort of thing, for people who are first arrivers, perhaps before the TFL, how do they get access to that kind of stuff?
Center voice can typically...
We didn't hear the question over here.
Okay, the question is, how much information will be shared via Cinema Voice? Typically, Cinema Voice is used for a fairly large call-out. This is for information, all about Ottawa Public Health. We can target groups within Cinema Voice, but typically if it's a call-out, you're not going to be giving a lot of detailed information. You're probably going to be giving detailed information once you know who the staff are going to be on site. And when you get the call and you're saying, yes, I'm available, you'll probably have a conversation with whoever's calling you, either the operations chief or the task force leader, saying, here's the directions, here's what you need to know, remember to bring this. When it really comes down to who's going to the shelter or to the ERLC, they'll give you more information. We typically wouldn't share that kind of detail to a large call-out. So yeah, I hope that helps. All good? All right. So in your packages, you have both the Emergency Health Risk Triage Tool Guidelines, and you have Emergency Health Risk Triage Tool. So guidelines are your backup to creating the tool. So just pull out your tool so you can follow along. This is your main documentation for your role. And as Jill mentioned, if you're going door to door, there's another form you need to fill out saying, I went to this house, I delivered this information, either by hand or the person wasn't there and I left it in their mailbox or whatever. This tool would only be filled out in a home visiting situation if you determine there's a reason to fill it out. You're not going to be doing this at every single door. You don't have time, and it's usually not necessary unless you see that there is impacts from the emergency, and now you need to focus and pull out this tool. So it's intended to help you quickly document your assessment. It is approved by the College of Nurses of Ontario. You do need to make sure that you use proper documentation standards. For example, you need to document what was assessed and what was not assessed. You also know that if you make an error, it's a strikeout with your initials, it's not whiteout. We have seen in past situations where people have used whiteout, and this is not nursing standards. So follow your typical nursing documentation standards. Next. So charting by exception is the term that means you're only documenting what has been assessed, and you're using check marks to document what has and what has not been assessed. And any exception from normal parameters. On the tool, they're called significant findings. In your guidelines, it provides you normal parameters. So we haven't, all the normal parameters are not on this tool. All of the significant findings are not in these guidelines. This requires nursing judgment to say this is not normal, or this is not normal for this client. For example, someone who has a chronic illness may fall within something that's not typically normal, but for them it's normal. So you'll be using your nursing judgment, and only examples of some situations are included on this tool. If there's something else, then add it to the tool. There's also room on the back for documenting your ongoing assessment and the progress notes. And in some situations, your whole team may want to be using specific acronyms or short forms, and you as a team should determine what short forms you're using or what's specific to the emergency. So in your team meetings, just make sure that you're documenting consistently among the team members. So we still need to follow OPH policies and procedures regarding confidentiality and consent. So at the end of this presentation, there's a list of all the policies and procedures you should be aware of. In emergency response, it's a little bit unique. You can share your documentation among the circle of care. So those workers in that ERLC with you, you could share it with your paramedic partners. You could share it with the Red Cross partners, the people in that ERLC with you. So confidentiality still needs to be maintained, and the person needs to know who you're sharing this information with. If you're going outside that site and you're sharing information with a CHC or the CCAC, or you're still going to need to get a consent to share outside that circle of care. So there are some consent forms in the bin, in the documentation. And just clarify with your task force leaders your parameters around how your document can be shared among the team. So for each indicator, you check off the status. Were they normal findings? And if you didn't assess it, you'll check in that box. You're going to indicate if a referral is made into whom, and any interventions that you have implemented, and your ongoing care in the progress notes. There's a very small box for progress notes on the back, so there are some blank, longer and blank progress notes that you can attach to your file as well. So again, refer to your guidelines for normal parameters and your assessment details. All right, so section 1 is your identification of the client. And I'm just going to skip through these quickly. Next slide, please. So if your paramedic partner is there, they may be doing this primary assessment to identify urgent health risks. For example, if there was a fire, someone has smoke inhalation, is in respiratory distress, the paramedics will be dealing with that. If you come across anyone who you think paramedics need to see, you would refer back to them. So you wouldn't need to deal with this section if the paramedics are present. So we're talking about airway, breathing, circulation, neurological, vital signs, general conditions, skin pain. There is a blood pressure cuff in the bin. There's a thermometer in the bin. You can use them if needed throughout your assessments, but if the paramedics see them first, they may do them first. Yeah.
So would you just skip this section, or would you put down as not assessed because paramedic or something?
That's right, you would put not assessed. So ensure that you check what you did not assess. Next slide. So the secondary assessment, so you're identifying health needs. So it may be that you're going to be there for a day, 2 days, a week, 2 weeks. The evacuees in Cornwall, they've stayed up to a month in the evacuation centers set up. So they may be deployed to these centers for quite a long period of time. So this is where you go through health conditions, mental health issues. I do want to say something in particular about mental health issues. Crisis situations will escalate any crisis situation among people with mental health issues. And it's very important to be very cognizant of your clients who may be escalating into a crisis situation in their homes. Anyone who's reacting to an emergency probably will not want to go to a shelter where there's 100 people. If they're paranoid or have any issues that, being in groups, it would be very difficult for them to go to one of these reception centers. So it's going to take a lot of skill by a nurse to support them in these situations. And there are some supports. The psychosocial support is provided by the personal services team, so you can make a referral to them. And hopefully they have people that are able to support people with mental health needs. Now, as far as medications, there's a section at the bottom. This is a very important section for the nurse because they may have evacuated from their home and did not grab their insulin or something that they need daily to sustain life. So it's very important for them to get what they need. And we've seen often it is the role of the nurse to help access those medications. Now it may be that they could send a firefighter back into their apartment to get that insulin out of their apartment. You never know. You just need to talk to your team and see what's possible. If that is not possible, you may be asked to get a new prescription, facilitate a referral to a physician to get that prescription, make arrangements for personal services or somebody to buy that medication, or just say, have you got a card? Maybe they can go get it. So whatever it takes to get the medication they need. If that setting is not appropriate for them, let's say that they're on home dialysis, this setting is not set up for a client to maintain home dialysis. They will need to have arrangements so that they can go to the hospital facility or another facility where they can have that done. So that's your role to find out what do they need to remain there for the period of time they're there. Another note about medications, the nurse cannot give medications in this setting. A nurse can only give medication if it's been, if you have a medical directive. And in most cases in this situation, we do not have medical directives. So you can open the bottle for them, you can get them some water, you can give them some food and they have to take it with food. You can facilitate them taking the medication, you just cannot give it to them. You can hand them the bottle. There you go. So just to be very clear about medications. In a immunization situation or a prophylaxis clinic, we do have a medical directive. And that's how we provide medication or administer medication. Next slide. And I just want to make sure there's no backup here. I think I covered everything there. Excellent. All right, so nurses are in a position to notice infectious disease in these crowded conditions. If someone comes to a ERLC and has measles, for example, that would be a problem. So keep your eyes open. You know, have they got something that could potentially be spread, respiratory illness? If you determine that there is a risk, there is an IPAC kit in the bin, and Suzanne, our IPAC trainer, is here with us. And hopefully all of you have attended your IPAC training. If not, speak to Suzanne. Use the PPE that you need to protect yourself and to prevent that client from spreading to others. Isolate them, notify your task force leader, and do what needs to be done to contain that illness and ensure that the appropriate follow-up is done. So after you've done all your assessment, your determination, can that client stay there? Do they have what they need to maintain their health needs in that setting? Can they stay there if they have the supports? For example, someone that requires wheelchair, walkers, maybe they left with nothing. The CCAC, you may be able to ask them to bring in what they need and they can stay there. Or the setting is just not going to meet their needs, they need to be referred elsewhere. Now, in a home visit, you're not as much focused on the individual as the environment they're living in and that the emergency has affected. For example, electricity, water, safe water, no heat in their house. Flooding has caused terrible mold in their basement. Somebody's got mold allergies. So you're assessing according to what the emergency has caused in their home. And if it's not safe, you would have to make a referral and do what needs to be done to ensure that family is safe in their home, or do they need to move elsewhere? A note about people in their homes, people with pets would be very hesitant to go if they don't have somewhere safe to bring their pets. As I said, people with mental illness would be very hard to encourage them to leave their home if they feel they're not going to somewhere safe, and they need the supports to be able to move somewhere safe. So that you could be dealing with situations that are a little bit difficult. Document your interventions. Decide what risk category they fit in. So your risk categories are defined in your guidelines. Are they high, medium, or low? What can you do to provide them the information? And what referrals should you make? Do they need to be relocated? And do they need any follow-up? And document any additional information. So this is where we get into the incident management system documentation. But before I leave the tool and the guidelines, any questions? Cynthia?
How does the part that the
So they're not
Do they
documenting.
ever come back together so that we can, I know we're not, if they're there, we're not doing it, but
Right.
I would want to know that information, so how does it come back together?
So they are not documenting on our tool. They have their own tool. So they may have seen a paramedic. The paramedic has determined that there's nothing urgent, and then they could refer them to us to continue the assessment, to look at the rest of the assessment. So we will not see the paramedic's documentation, and they will not document on our tool, but we can talk to them. And when the referral comes in, they'll say, we've done this and this and this, they're okay, now you can finish the assessment. So it's more of a verbal sharing. Yes?
Just to refresh my memory, to go back to the medications. Client has their own puffer or nitro spray or baby aspirin or something. As a nurse, I'm handed to them, they do it themselves, but I can't administer the nitro spray, let's say, I can't remember.
So the question was, can I just clarify the medication? So they arrive with their own medication, and what the nurse can and can't do. So you could retrieve that puffer out of their purse. You could get them a glass of water, open their bottle for them. You could get food to help them take that medication, but you cannot actually push the puffer or hand them the pill. They'll need to pour that pill out of that bottle by themselves.
And then I would document that I retrieved or whatever.
Sure, yep. Client took medication at such and such a time, and you just, yeah, that you helped them, that you're aware that they took it, but not that you gave it to them. Anyone else? How are we doing for time? Okay, we'll talk a little bit more about INS. Oh, thank you.
Actually, just a question about the home assessment. Because some of these living conditions could be like pre-existing before the emergency. So if it's pre-existing, just assume it's low risk because they, but you still kick it off. Because they may not want any assistance for something like that.
So the question was, if there's a pre-existing condition before the emergency, and you feel it doesn't need to be assessed, it's the same as it always was, you could document that they have this pre-existing condition, and that there's been no further impact on that condition. Something fairly general to say that that person is in their normal state. But has the emergency caused a situation where they cannot manage that chronic condition for some reason? They don't have the water, they don't have the electricity that they need to run a respirator, that kind of impact. Yes?
Can we share this information with anyone, like paramedics, anyone on site? Is it kind of like hospital setting, or do we have to be?
So it's considered a circle of care. So right, it's considered to be your circle of care within that ERLC. So your partners are your paramedics, your first aiders with the Red Cross, your health inspectors, so it's and your psychosocial team as well. So sharing within that circle of care is acceptable as long as the client knows, I'm walking over there and I'm going to be talking to the paramedics about this situation that we've discussed. So. Yes?
How does the Good Samaritan law apply? For example, if you have somebody in front of you and they're having chest pain and you're saying, oh my God, I'm going to have a heart attack, why would you not be able to spray the nitro into the child?
Well, in any situation with CPR, We are trained in CPR. In this situation, I am not the best person to answer this question, but I would assume that we possibly could give them their nitro. No? No, could we give them the bottle and
Yes.
say, take your nitro yourself? Are you saying if they're collapsed and cannot take their nitro?
Or they're unable to grab, to administer it themselves.
No.
The Good Samaritan is for not us, it's for non-healthcare people, people who are helping someone on the side, you don't have to say, but for us, we can.
Okay, thank you for clarifying that. I didn't want to give you the wrong answer. So no, it's like any medication that they need. If the paramedics are there, I would make an urgent referral to the paramedics. If the paramedics are not there, I would also make an urgent referral to them. Yes.
I'm just thinking that an EpiPen may be different. EpiPen, child, whatever, has their own EpiPen, I can use that.
Yes, I believe we have a medical directive. Correct me if I'm wrong, do we have a medical directive for EpiPens?
For the clinic.
For clinics, but what about
But school nurses that teach
school nurses that teach them?
I don't think so.
There's no,
Only for the clinic.
School bus drivers got a medical directive about 10 years ago.
Yeah, but that's not on minister. I think the training in the schools that you tell people is that we cannot do it. Is that right?
so, okay, we're having some good clarification. So, yes.
They say like you can do the EpiPen, but that's the only medication you can get. But it's life-threatening.
So we should clarify this.
We do have a medical directive for epinephrine, which would probably, is that part of the kit for the?
That's in clinic, immunization clinic.
Is it,
The sexual health center have that?
yeah, but is it in, would it be in the kit, I guess? for
There's
emergency?
no medication in these kids, no.
That would be.
Yes.
Kathy, I think it might be worthwhile for your team to verify that Good Samaritan law that Dan was talking about, because I remember this coming up at CPR training. I think it even came up this year when we went, and I believe I understood that nurse aside, like putting your professional designation aside, that in an emergency situation, so someone, for example, is having a heart attack, you could in fact administer the nitro. So I don't know if you, I'm not just gonna check because I'm confused a bit about it, but I think it might be worthwhile to know that because that changes a bit the message.
I
The
agree.
Good Samaritan Act says that any person who comes upon an accident can do what they can do to help, will never get sued. But if I'm not a medical person, the Good Samaritan Act is for all the population that aren't trained. As my training as not a doctor, I can't give medication. I can't administer medication, I can't do it. So as a lay person, I can try to give CPR, I can try to stop breathing, I can try to pull them, I don't know, out of the bathtub, but I can't give them medication because that is not something I'm trained for. So the Good Samaritan Act does protect all the population who want to provide first aid and help, but that doesn't include giving medication.
I'd like to suggest that I take this offline and do a little bit more consultation and clarification. And I have all of your names. I can follow up with some further information. We could get into quite a discussion about it, and I'm a little conscious of the time, but I will follow up and I will get back to you. Okay, over to Jill. Thank you.
And as you all know, the medication and what nurses can do and not do is being revised. So whatever happens in the future about nurses being able to give medication without a prescription, and in the case as it is right now, whatever we find out, we're going to add to the materials that we give you and the reference sheet, and as well as emailing it out. That's a really good question. So, IMS documentation. Now, I know in an emergency, the city has adopted, and OPH, through our standards and through our regulations, has adopted incident management system documentation, which is a little different than, it's more or less the same idea, charting by exception. You're only charting those things that are significant, something that makes a difference in the care that you're giving, or something that you've observed is important, and it's not done on our ordinary charting. So we have adopted, and actually the city has gone to the point now where when they're in enhanced or activated operations, all of their reporting into the Emergency Operations Center and amongst the service command centers is going to be done online using incident management system forms. That's the new way of moving forward, and those duty officers for public health are all going to be trained starting tomorrow. So there are two pieces of forms in the bins, which I'll be showing you momentarily, that you will be documenting on. You do not need to document on anything else. This is besides the health risk assessment form, which is a nursing document, aside from the reporting up. So the unit activity log is a synopsis of what is happening for the team, what occurs under the direction of the task force leader, and it's for a certain period of time. So at the top, there will be an incident name, and that's very important. So at the onset, they decide what the incident is going to be called. We did an exercise yesterday, we called it Operation, it was Ottawa Hotspot. And so that, all of the documents that are created during an incident will have the same title on them. And for the operational period, this is not a regular shift. It might be 10 hours, it might be 2 hours, it might be 12 hours. It should never be more than 12 hours to avoid burnout. But that period is important, and it's not going to be a regular routine time that shifts normally are. And so the IMS position that you're fulfilling and what home organization you belong to. And then what we've got here are who are the people that have been deployed to your team and where they come from. And we have added a little bit of information to this form because we used to have an Excel document that came out from our finance people that had to be filled in as well, which was very time-consuming. It asked which ones of your staff had been deployed for IMS and how long and whether it was overtime. And what we're doing now is just capturing it all on the unit activity log. So this will also maybe be used for claiming money from the province after it's all over. So we need to be accurate with the amount of hours that staff worked for that period of time and whether it was overtime or not. And then the second page is the activities, significant events that happened. So don't, if it's a normal shelter and everybody's just there until